We'll now discuss a few trauma-informed treatments. There are many different evidence-based trauma-informed treatments. This slide lists some examples that are used with people who've experienced trauma. They include cognitive processing therapy, cognitive therapy, individual cognitive behavioral therapy with a trauma focus, prolonged exposure, and eye movement desensitization and reprocessing, or EMDR. The website for the International Society for Traumatic Stress Studies, ISTSS, includes fact sheets on many of these evidence-based treatments and promising practices. There is no one-size-fits-all when it comes to treatment for people who have experienced trauma. However, research has shown that most effective trauma-informed treatments include some common elements. First, they are based on scientific evidence, rather than just someone's idea about what works. This means that these treatments have been systematically studied, and data demonstrating their effectiveness have been published. They include a comprehensive trauma assessment to determine the person's trauma history and needs. After the assessment, the provider proposes a treatment plan, which includes involvement of the person and their caregivers. Trauma-informed therapy actively addresses the person's traumatic experiences and traumatic stress symptoms. This type of treatment has been proven effective for people of every age, from infants and toddlers to teenagers to adults. It is never too late for a person to seek treatment for a trauma-related response. Sometimes there may be a lack of caregivers who can provide an accurate history of trauma experienced by the person, such as children who grew up in foster care. Or records or documentation may not be available. In such cases, providers may have to rely on the person's perceptions of what happened, or their ability to communicate about it. Many effective trauma treatments rely on cognitive behavioral strategies to help people challenge thoughts that are not serving their recovery. These strategies allow people to express their emotions and feelings about the traumatic experience in a way that feels safe for them. Several studies have shown the effectiveness of treatments for traumatic stress that are based on what psychologists call cognitive behavioral approaches. These approaches include teaching people stress management and relaxation skills to help them cope with unpleasant feelings and physical sensations resulting from the trauma. Using what therapists call exposure strategies, or talking about the traumatic event and feelings at a speed that doesn't distress the person. Creating a coherent narrative or story of what happened. It is often a difficult process for people to reach the point where they are able to tell the story of a traumatic event, but when they are ready, the recounting enables them to master painful feelings about the event and to resolve the impact the event has had on their life. Exploring untrue or distorted ideas about what happened and why. People sometimes think they did or didn't do something to have caused the trauma, or that if they had only acted a certain way, a traumatic experience might have turned out differently. This is rarely true, and getting the story right helps the person stop prolonging the traumatic stress by punishing him or herself. Changing unhealthy or incorrect views that have resulted from the trauma. People often need help to overcome such ideas such as, if he did that bad thing to me, it must be because I'm bad, or people like me can never have a normal life again. Involving caregivers. Caregivers can play an important role in treatment, sometimes by participating in interventions with a therapist and by helping the person practice new strategies at home. Caregivers have key information about the person they support that therapists need in developing and implementing treatment. Most importantly, caregivers can create the stable, consistent, and caring environment in which the person can learn about a traumatic experience and that it doesn't have to dominate their life. We now know that there are clinically sound treatments for trauma that are indeed helpful for people with IDD. On the next slide, we'll review some adaptations for people with IDD. When working with clients with IDD, therapists may need to make some adaptations to their typical approach. This may include increased psychoeducation, spending time building an emotion vocabulary, especially the emotions that will be the focus of the therapy, and helping clients to be able to differentiate between thoughts, feelings, and behaviors. Therapists will generally need to modify the pace, both within a session and across the course of therapy. This may mean more therapy sessions than is typical. Therapists should also make sure to frequently review the concepts, practice skills multiple times in the session, and review previously learned materials. One of the core challenges for many people with IDD is difficulty transferring learning from one setting to another. They may learn and demonstrate a skill at a day program, but have difficulty demonstrating that same skill in the workplace. Similarly, they may practice and learn calming skills in therapy, but have difficulty doing so at home, work, or day program. Therapists will need to work with their client and his or her support network to identify the settings that are likely to be challenging and create opportunities to practice the new skills in these settings. Using visual supports will help the person with IDD understand the abstract concepts often used in therapy and know what to expect across the course of treatment. Therapists should also be open to using augmented communication devices or allowing a trusted caregiver help with interpretation for clients with communication challenges. Narrative-based approaches may be modified by using drawings, collages, photos, audio recordings, or other appropriate modifications instead of written or verbal narratives. For therapists who are interested in learning more about specific CBT strategies for people with intellectual and developmental disabilities, can find resources in books and online to help guide them in making modifications to their usual treatment practices. Brian Talent has made adaptations for trauma-focused CBT for children and adults with IDD. He suggests that TF-CBT is a good model to adapt because it is a strength-based approach. It focuses on development of competency skills. It uses cognitive behavioral treatment techniques, which are relatively easy to adapt for people at different developmental levels. It has already been structured for use across a wide range of developmental levels, and it focuses on developing skills that are associated with greater resilience, including a strong self-esteem, ability to self-soothe, and feelings of competency to deal with challenging situations. Ideas for adapting psychotherapy for people with IDD include slowing down your speech, use language that is comprehensible to the client, present information one item at a time, take frequent pauses during the session to check comprehension, use multisensory input, make specific suggestions for change, allow time to practice new skills. Do not assume that information will generalize to new situations. Include multiple caregivers in various environments. This slide is an example of just some of the specific adaptations he suggests for the trauma narrative component of TF-CBT. IDD may impact a person's ability to communicate trauma history verbally. Many treatments rely on cognitive skills, such as a trauma narrative. Providers should identify the cognitive floor for use of a particular therapy and use nonverbal, multisensory tools when necessary. Remember that change may occur more slowly with some people than with others. Measuring change with a micrometer rather than a yardstick. Remember that effective treatment for people with developmental disabilities must also include a variety of support and education services for families and caregivers. It is important for providers to be thoughtful about how to modify intervention strategies for people with IDD, particularly evidence-based interventions which have specific treatment protocols in place. For example, if an intervention is focusing on identifying trauma reminders, the task for the provider may be to come up with alternative strategies for a person who has limited verbal abilities to address reminders. For example, teach the person to take your hand when experiencing a reminder versus relying on verbal communication of that reminder. You may be a trauma-informed therapist, or you may be another provider of services making a referral. This slide lists questions to ask therapists or agencies that provide services to determine whether they are trauma-informed. Workers may feel uncomfortable asking these questions of mental health providers, but people who have been impacted by trauma need and deserve a specialist, just as people with serious dental problems need an orthodontist. So ask providers, do you provide services to people with IDD who have traumatic experiences? How do you approach trauma therapy with people and their caregivers who have had a traumatic experience, regardless of whether they indicate or request trauma-informed treatment? Do you provide trauma-specific or trauma-informed therapy? If so, how do you determine whether the person needs trauma-informed therapy, such as through screening or assessment tools? How familiar are you with evidence-based treatment models designed and tested to treat people with trauma-related symptoms? Can you describe the core components of your treatment approach? It's important to point out that not all people exposed to trauma need trauma-informed treatment. Some people benefit from sports or participation in a mentoring program. These other services can also be used in conjunction with trauma treatment. Due to overlapping disabilities, quality trauma treatment involves integrated care between caregivers, mental health providers, primary care providers, medical specialists, special educators, advocates, and developmental disability services. It is critical to involve caregivers in all environments, and intensive care coordination improves outcomes of treatment. In contrast to a fragmented approach, cross-system coordination views the person and family in a holistic manner. When different systems have many different and potentially competing priorities, there is a risk that people with IDD and their caregivers will receive mixed or confusing messages, or simply fall through the cracks. Conversely, these multiple agencies and individuals also have the power, individually or in combination, to actually inflict secondary stress upon the person. For example, in some communities, when sexual abuse occurs, the person might be re-traumatized by having to tell about details of the abuse on multiple occasions to 5 or 6 different interviewers representing various agencies. Though designed to protect people with IDD from further abuse, these interventions can be immensely stressful for people with IDD. People with IDD and their caregivers often have legal issues, including denial of benefits, special education, personal welfare or juvenile justice involvement. Attorneys and judges could use some guidance on IDD and trauma as well. Strategies for cross-system collaboration include cross-training on the intersection of trauma and IDD, jointly developing protocols regarding trauma and collaborative services that promote resiliency, creating multidisciplinary teams, schedule regular team meetings, co-locate staff in clinics and community hubs, identify and utilize cross-system assessment tools, share knowledge of local resources and trauma-informed treatment options, and integrate information sharing systems. Be cautious that involving multiple providers and collaborating across systems doesn't result in a diffusion of responsibility to the point that no one is responsible for the person anymore. Work with your organization to establish meaningful long-term changes in policies and practices that support not only adults with IDD, but also the providers who provide care. Changing an organization's policies, practices, and culture can take commitment, time, and expense, but is likely to result in improved client and organizational outcomes. The Institute on Trauma and Trauma-Informed Care at the University of Buffalo has developed a manual to guide organizations in adopting trauma-informed care practices. Time to put this all into practice. You're now going to work with the case vignette that you chose earlier to answer the following questions. Name the protective factors that are apparent for the person you chose. Feel free to speculate about protective factors or make a list of ones you might expect to be present but you aren't sure. Asking caregivers about what works and what hasn't worked in the past is helpful for moving forward. Are there protective factors you want to keep in mind when referring this person for additional services or treatment? We'd like you to identify what the challenges and barriers for the person for your case. How might that person have difficulty accessing services? And finally, we'd like you to come up with a few ways that you would advocate for this person. What would you want to screen for? Start thinking about what planning for services would look like for this person.